All right, I think we'll get started here. Got a good crew here. Hello, everyone, and welcome. My name is Stefan Wheat, and I'm a clinical fellow with the Global Consortium on Climate and Health Education. And I'm very pleased to be able to help moderate the third skills and practice session for the Caribbean Climate and Health Responders course. Today, we'll be presenting all of you with a clinical case related to climate change and health. We have some phenomenal actors who will be playing both the part of the clinician and the patient today. Your participation is really crucial to these meetings, so please put your questions and comments in the chat when prompted during the case. We'll be able to try and address as many of them as we can at the end of the session. I also want to just remind everyone that CME credits are available for these sessions, and you can scan the QR code here to claim your credit, or use the link that I think one of us can post in the chat. I'll just give everyone a moment to grab that if they can. With that, we'll launch into the case. So today we have a case on heat and mental health. And we start off with a patient named Jody, who is a 30-year-old female who has worked as a store clerk for 15 years. She's brought to medical attention today by her coworkers, who state that she appears confused at work this afternoon. Her only medical problems include diabetes and schizoaffective disorder, which has been well managed on clozapine. She presents to a public hospital in an urban area, and the overall tone and demeanor that Jody presents with is friendly, but somewhat slow to respond, and she seems somewhat out of it. And with that, I'll turn it over to our actors.
Hi, good afternoon. My name is Dr. Lavo. What's your name?
Jody Chantal Bender, doctor.
Hi, Jody. It's nice to meet you. I'm sorry it's under these circumstances where you're not feeling well. How old are you?
I'm 30 years old, doctor.
Can you tell me a bit about what brings you into our health center today?
Don't feel like myself, doctor. I feel like I'm in a daze. My coworker said I wasn't acting right, that I was acting funny at work, and they brought me in.
Okay, and I know they're in the waiting area, and I'll speak to them shortly. You want to tell me more about that?
I just worked a 12-hour shift, doctor, and it was really hot today. I just felt like I couldn't cool down. I was walking around the frozen food section, trying to stand in front of the freezers, trying to cool down. And doctor, I haven't been sleeping well. I've been taking Benadryl to sleep, and my friend told me I needed to come here because I just didn't seem right.
Okay, no problem. I want to ask you some more detailed questions, Jody, just so we can find out exactly what's happening with you. When would you say you first noticed that something just wasn't right, that you didn't feel yourself?
I was at the beach today, doctor, and it was the worst. I feel a little bit better here with you in the air condition, but I guess since the heat wave started, I've been feeling really off, maybe a couple of days. Do you think Greenland gets as hot, doctor? I mean, also, doctor, I haven't been sleeping well. I've been taking Benadryl to sleep at night.
Right, I recall that you told me you got from the pharmacist. Has anything like this ever happened to you before? Feeling this way, having problems sleeping?
Nothing like this, doctor.
So I want to ask you some more questions, just digging a little bit deeper. I know you said you felt off since the heat wave started, but even before that, how long has this been happening?
Just the past couple of days, doctor, really more with the heat wave. It was the worst it's been this afternoon when I was at the beach.
Okay. You said your coworkers said that you've been out of it. Did they tell you that you appeared confused in any way?
They said they couldn't understand some of what I was saying. I mean, I feel a bit like I'm in a daze, doctor. I feel a bit foggy.
Okay. Have you had any headache, any weakness to any of your limbs? Any twisting of your face? Did your speech seem slurred to you?
I did have a headache, doctor, these past couple of days with the heat, and I just can't really think straight.
Okay. Have you been having any other symptoms? Having any pain?
Feel really tired, doctor, and really sweaty, doctor, like a little pig, like I need a mud bath. I also have cramps, doctor, in my legs and my back, and I feel nauseous, doc, like I want to throw up, and I can't think straight. I really struggle. My coworker said I didn't make any sense earlier today, and I don't know, doctor.
And I'm sure that's why they were concerned enough about you to bring you for help. You said that you were having cramps in your back and your legs. Have you been having any numbness or tingling to your legs at all, or difficulty walking?
No, doctor.
Has anything made your symptoms better? Has anything made it worse?
I think it's worse in the heat, doctor, especially outside. I mean, I tried to cool down. I had a shower before I came here, and I've been using the cool washcloths on my face and a fan, always using the fan, but nothing seems to help me stay cool. I just can't seem to stay cool.
Okay. I want to ask you some other questions, Jody. They may seem unrelated, but it's to make sure that we don't miss anything. Have you had any recent cough, runny nose?
No, doctor.
Any chest pain, any shortness of breath, palpitations, feeling your heart beating quickly?
No, doctor.
I know you said that you felt nauseous before, but have you had any vomiting, any pain in your tummy, any change in your bowel habits?
No, doctor.
Just lastly, any change in the color of your urine or how frequently you're going to the bathroom to pass urine? Any smell to your urine?
My urine has been a bit darker yellow than usual, and I've been really thirsty, doctor.
Okay, and have you been drinking more water since you've been feeling more thirsty?
Not so much. I work at the supermarket and we don't really get bathroom breaks, so I try not to drink too much.
Okay. Thank you for answering those questions. I want to ask you some questions about your past medical history. Are you known to have any medical illnesses, Jody? Diabetes, high blood pressure, asthma?
Diabetes, doctor.
You have diabetes, and that's well controlled?
Yes, doctor.
Do you have any other illnesses that you see a specialist for that I didn't mention in that list before?
Yes, doctor. I have something called schizoaffective disorder. It's where I might see and hear things that aren't actually there, especially if I don't take the medication. One time I tried to climb a lamppost because I thought the lamp was a mango and it was mango season. And that's when my friends thought something was off and they took me to the hospital, and that's when I got diagnosed.
Okay, and thank you for telling me that. I know it's often hard to speak about having a psychiatric illness. You said it's been controlled on your medication, but I just want to ask you, these symptoms that you're having now today are similar to the symptoms that you have with your schizoaffective disorder, or do these ones seem different?
I think they seem a bit different. I usually don't feel this hot or sweaty or have cramps or anything like that, doctor.
Okay. What medications are you on for your diabetes and your schizoaffective disorder? Do you have them here with you?
I brought the box for you, doctor. I take metformin for my diabetes, and I take clozapine for my schizoaffective disorder, and well, the Benadryl that I've been using to sleep.
Okay, how long ago did you start the Benadryl?
Maybe a week.
Okay, no problem.
Just a couple of days.
You take your medications. Have you had any recent change in the doses of your medications?
No, doctor.
Okay. Are you allergic to any medications?
Not that I know of, doctor.
Have you ever had any surgeries before, Jody?
No, doctor.
Does anyone in your family have any illnesses at all?
I'm not too sure, doctor. We don't really discuss medical histories. I think maybe some diabetes and high blood pressure.
Okay. I want to ask you some questions that may seem a bit personal, but remember, it's just for us to be able to offer you the help that you need. Do you smoke or drink alcohol, Judy, or use any other illicit drugs, cannabis?
Nada for me, doctor. Not for 10 years now. I'm high on life.
That's understandable. Who do you live with?
I live with 2 of my co-workers.
You want to tell me more about your living situation? How is that?
Sure.
Ordering amenities and so?
We rent a house, which I wish was in the Swiss Alps, doctor, but but we rent a house. It's a 3-bedroom house. We share the bathroom, shower, kitchen, sitting room area, and we each have our own bedrooms. It's a cement concrete structure. We don't have air conditioning, but we do have fans. We usually use the fans to stay cool. We keep the doors and windows locked because the area sometimes isn't very safe, and we have horrible mosquitoes. So to keep them out, they're both out for blood these days. So we keep those tightly shut.
Okay, no problem. And what kind of work do you do, Jody? I remember you saying about shelves and storeroom. What exactly do you do? What does your job entail?
I work at Jelly Beans, the supermarket in town. And one of my co-workers works at Green Beans, the greengrocers in town. I basically stock shelves. I'm in the back a lot. We don't have air conditioning. Sometimes I help with the cashier and the cashing in front.
Okay. Do you get any symptoms when you're at work?
Just feeling really hot, doctor, and sometimes with the heat, I feel nauseous.
Any of your co-workers or your roommates, they've been having the same symptoms you've been having?
They complain about the heat too, doctor, but they seem to be able to stay cool. I just seem to be the only one who can't.
So Jody, you've given me a lot of information. Starting to put the pieces of the puzzle together about what's happening with you. I'm going to excuse myself from the room for a few minutes, and I'll be back shortly so that I can examine you. Is that okay?
Yes, doctor.
So I was able to take Jody into the clinical examination room. When I examined Jody, her overall presentation, she was well developed and well nourished. She looked mildly anxious and was flushed in appearance. Her vital signs were done by the triage nurse prior to me seeing her. Her temperature was 39 degrees Celsius. Her blood pressure was 105 on 70 millimeters of mercury. Her pulse was 130 beats per minute and regular. Her respiratory rate was 24 breaths per minute, and her blood glucose level was 5.4 millimoles per liter, which is 97.2 milligrams per deciliter. On my physical examination of Jody, her neurological and mental status, she seemed slow to respond, but she was oriented in person and place, and she actually had equal power throughout. Her HENT examination, her mucous membranes were dry. Her pupils were 7 millimeters bilaterally and reactive. Her heart, she was tachycardic in keeping with her triage vitals, but it was regular. S1 and S2 heart sounds were heard, no murmurs or no additional sounds. She was tachypneic, but her chest was clinically clear. No creps or wheeze auscultated. Her abdomen was benign. She had no signs of trauma or bruising, particularly because she was confused. We checked for any evidence of head trauma. There was none. Her skin seemed dry. Given both her confusion and the fact that Jody had a history of schizoaffective disorder, her MSD was done. She had a delayed response, but it was appropriate. She had no suicidal or homicidal ideations, no hallucinations or delusions, but she was occasionally tangential in her speech. I thank you
Fantastic.
for allowing me to examine her while I went back to the workstation to formulate a differential diagnosis.
Great. Thank you, Lynn. And now we'd like to invite all of you to consider what the potential differential diagnoses for this patient's presentation could be. We invite you all to put your answers in the, and we'll take a few moments before we go forward.
Okay, so I'm seeing hyperthyroidism, which is a good one. She was tachycardic, and she was tachypneic, seeing heat stroke with dehydration. She did keep saying that she was thirsty a lot, so that was something I was considering. I'm seeing thyroid again. So a lot of them are, I think we're all along the same lanes. We're thinking heat illness. I'm seeing dehydration popping up a lot, premature menopause. Maybe I should have included her neck examination, but that was fine. I didn't see a thyroid swelling when I examined Jody. She didn't have any evidence of the goiter. Definitely, she could have had uncontrolled type 2 diabetes, and this could have been a presentation of a diabetic emergency, HHS or DKA. Okay, endocrine disorders, which will encompass both the diabetes and the hyperthyroidism. Any other things that we want to include? Yes, we did get her blood sugar, and that was normal. So I actually didn't have that in my differential list when I saw her. It was something I was keeping in mind during the history, but we got the blood sugar, that was normal. We were able to rule that out. Poor air quality, early menopause. Anything else taking into account her past medical history and what we know about her medications? Anything anyone else wants to add to widen that differential diagnosis list? A couple of things I haven't seen yet. I think whenever we see a patient present with a temperature of 39, okay, who's tachycardic and tachypneic, okay, adverse reaction to clozapine, Benadryl overdose, leptin syndrome, depression. Right. So we do know that metformin has some GI symptoms as well that can lead to her dehydration. Sepsis. Yeah, sepsis is a big one, which I didn't see before. Of unknown origin. Infection, I'm seeing Rosanna, malignant hyperthermia. Okay. Stefan, I think everyone has their thinking hats on. We're all going along the same lane.
Fantastic. Great. So then the next step for this case is we'd like, again, to consider what the next step should be. What kind of workup do we need? What kind of treatment is needed? And other management, what kind of other management you would pursue? Again, please put your answers in the chat and Lynn will help to moderate.
So obviously everyone's next steps may vary based on what you thought was happening with Jody. But I'm interested to see all of them. So you can go ahead and type urea and electrolytes, coming fast and furious, use needs. Any particular things we wanna, if you can type anything you wanna look for specifically in the UNE, you can do HbA1c, okay. An idea of her diabetes function. I'm seeing CBC. I'm assuming that's to look at her white blood cell count since we entertain sepsis as a diagnosis. Blood culture, she is febrile, seeing early antibiotics. So hypernatremia, okay. TFTs, so a lot of people did mention that they thought she may have had hyperthyroidism, and likely probably not just simple hyperthyroidism, but thyroid storm might have been contributing to her symptoms. So yes, TFTs. So I'm seeing a lot of investigations. I'm now seeing some treatment, increasing hydration, improving the ventilation at home. So we're talking about improving the ventilation at home. Do we think that she's a person that we have to admit? Are we going to monitor her? Do we think that she can return to her circumstances right now? That's their ultrasound, treatment contingent on labs. So we'll definitely be sending off labs for her, but in the meantime, we still need to treat Jody, who just keeps telling me how out of it she is, and she's so hot and she's so confused. So what can we do to at least help her? Okay, clozapine can cause a transaminitis, so LFTs. Okay, increase hydration and cooling at home. Because she did say she was feeling thirsty a lot, and when I asked her if that meant she was drinking a lot more water, she actually said no to that. Antipyretic cooling measures. Okay. So Stefan, I think we have a lot. Do you want me to start with what my differentials were?
Please go ahead.
I'm gonna go home until temperature and pulse improve, right? So when I saw Jody, my first diagnosis, especially with the heat wave, the fact that she was at the beach that day and outdoors, my first differential was heat exhaustion with early signs of heat stroke, since she was having a headache and confused. But my differential list looked a lot like yours as well. It could have been a medication reaction secondary to the clozapine, and one big thing to entertain with that was neuroleptic malignant syndrome, and also related to the Benadryl use as well. Entertain sepsis. I mean, she was confused and out of it. She was febrile. Was she really febrile or was she hyperthermic? Guess we're gonna find out shortly. But she had a high temperature. She was tachycardic. She was tachypnic. Her sulfa would have made her septic. It was trying to figure out what was the cause of that sepsis. So that was definitely another differential. Could have been worsening of her underlying mental disorder, you know, her schizoaffective disorder. I said with the sepsis, we were trying to figure out exactly what was the source of her sepsis, but given that she was having the headache and confusion, meningoencephalitis is definitely something that we could have considered. And then we always keep our differential list as wide as we possibly can, so that we don't miss anything. So then we moved on to her workup. Lots of the things you guys have already said. Checking her CBC, her complete blood count, checking her chemistry, looking at her sodium, her urea and creatinine, doing blood and urine cultures to screen for sepsis. It may have included a urine drug screen because she could have had toxicity for another reason or overdose. She said she didn't use any illicit drugs, but cocaine was still something to consider. Doing her thyroid function test, and also getting her an ECG, because even though the heart rate felt regular, she was having a pulse rate of 130 beats per minute. The treatment that we instituted for her at that time, or that we want to institute, cooling measures, placing ice packs into her armpits and the groin areas, getting those large vessels. We actually turned up the AC in the room that she was in to help encourage cooling. When we had established IV access, when we took off her blood test, so she was getting IV fluid replacement with 0.9% normal saline. And she complained of a bit of nausea, so we gave her Gravol. And I held her clozapine and her Benadryl dose as well. All right.
Fantastic, Lynn. Thank you. So I'll let you pass it off to finish up your clinical encounter.
Thank you. So let's go back into the room with Jody so we can tell her what we are thinking. Hi, Jody.
Hi, doctor.
Hi. So I've had a chance to review the information and also your examination. And I think that your diagnosis is of something called heat illness.
Is that why I've been having such a hard time staying cool, doctor?
Yes, that's a part of it. So heat illness, so normally our bodies are able to regulate our temperature, but particularly with climate change and the heat wave we've been having now, it makes it a bit harder for our bodies to be able to do that. You might wonder to yourself, well, my co-workers and my flatmates, they haven't had any problems doing that.
Yeah.
Because sometimes other factors can interrupt that. So the fact that you're on the clozapine, which I do understand you need to take for your schizoaffective disorder, it stops your body from being able to regulate your temperature as it usually would. And the Benadryl, even though the pharmacist was trying to help you to give you something to sleep, that would have made it a bit more difficult as well. You understand everything I've said so far?
Yes, doctor. Does that mean I'll have to stop the clozapine?
So those two force one.
We'll actually have a discussion with your doctor, your psychiatrist who manages your schizoaffective disorder, because we may have to stop the clozapine for the time being, or we may just have to adjust the dose just so that we can have a good outcome. With the heat illness, sometimes you can just have a minor symptom, such as like the heat cramps, which you told me you were having. Sometimes that can move on to heat exhaustion, and sometimes it can even progress to something called heat stroke, which because of your confusion and the headache you've been having, I do think you have early signs of. We want to keep you for a couple of hours. Want to put in an IV for you, start giving you some fluids, giving you some stuff to help cool down. I know that you kept telling me that's something that's been concerning you. We want to run some blood tests to also make sure that it's not anything, like there's not infection going on. There's your thyroid, which is responsible for your body doing all the activities. You want to make sure that that's not affected as well. I'm going to ask the nurse to do an ECG for you just to check your heart rate, because we do want to make sure that whenever you are fit to leave, that you are feeling much better. All right. How
Yes,
are
doctor.
you? Understand everything I've said?
I think so, doctor. You said that the heat wave is affecting me more than my coworkers and my housemates because of the medication that I'm taking, that it's making me feel more warm and have a harder time cooling down.
Yes, that's definitely one of the factors. Do you have any other questions or concerns, anything that we didn't address while I was speaking to you before?
No, doctor. I think I understand.
All right, Tasha. So I'm just going to get those things so I can start treating you, and hopefully you'll feel better soon.
Thank you, doctor.
You're welcome.
Great. Well, I'd first like to just thank both of our actors, Tasha and Lynn, so much. You just brought that case to life in such a remarkable way. So thank you so much. At this point, I'd like to continue the session by asking the audience what you think the most important learning points from this case are. What can you take away from this case and help integrate into your own practice? We'll take a few minutes to think about that, and then we'll move on to some learning points. Marvin, you're right. I think everything seems to suggest that this will be increasingly a problem. And Julietta, I think you're spot on. It's even in a fairly clear-cut case such as this, it's important to keep a broad differential diagnosis and think about all the other things that could be going on. And yeah, taking a really thorough history, the environmental history that Lynn took was really the linchpin of us being able to identify what was going on here, I think. And Craig, yeah, that's one of the most important pieces for this case, is that there are certain medications that will exacerbate reactions and make some people more susceptible to heat-related illness. Yeah, social vulnerability is really, really key piece here, Cecilia. I think, that's another thing that Lynn did a really good job of ferreting out here. Some of the, again, some of the environmental factors that relate to the patient's social vulnerability that may make them more susceptible to heat-related illness. And yeah, Monica, looking out for the signs and acting quickly, you're spot on there, especially for patients who are presenting with signs that could be consistent with heat stroke. The morbidity and mortality from heat stroke is really, really high. And it's important to keep high in your differential because it's important to act fast. Thanks, James. Yeah, James. Yeah, the feels like temps. It's an important point. Something I think we'll get to in our teaching points. Yeah, and modeling, how to take an environmental history is a really big part of what these skill sessions are about, and how you can, clearly integrate, climate-oriented environmental history questions into your, history taking. Yeah, that's a really good point, Helen. It's for some of these medications, especially the psychotropic medications, they're not safe to stop abruptly. So, thinking closely, recognizing that many of these psychoactive medications can increase your susceptibility to heat-related illness, recognizing that there are also risks to, discontinuing those medications in an abrupt manner. Yeah, Sandra, that brings up a really good point, that there are certain patient populations, especially the elderly, in combination with all of the, medications that many of them are often on, that make them particularly susceptible. And yeah, Tasha, I totally agree. Lynn's bedside manner was amazing. I think we could all aspire to be as wonderful as Lynn is with her patients. Well, great. Thank you all for putting your comments into the chat. I'll share my screen again, and we'll go over some teaching points at the end of this case, and then we'll have a little bit of time, hopefully, for a Q&A. So again, big thank you to Lynn and Shasta for bringing that case to light. I just want to start off with a bang here, and this is a graphic from a relatively recent article that shows heat exposure for the Caribbean across different climate scenarios, from 1.5 degrees of warming to 2.5 degrees of warming. And what this figure is showing is something called the WSDI value, which is the longest annual warm spell duration. And what it shows is a large magnitude and increase over the entire Caribbean region relative to present baseline. for all global warming targets, whether it's 1.5 degrees, 2 degrees, or 2.5. And overall, the suggestion from this figure is that a significant portion of the year will exhibit consecutively warm days for even just a change in temperature of 1.5 degrees, increasing from a range of 59 more days to 187 more days from the present day baseline. And just taking a step back, I think one of the classic bell curve is a really useful way of considering some of these trends. And in this case, what it represents is the distribution of all temperatures at a location. And the bulk of those temperatures, those close to the average, sit near the middle of the curve, as we all know. And record temperatures, which are rare, sit on the fringes, with hot on the right and cold on the left. As the world warms, what we expect is that from an increase in greenhouse gases, the whole curve will shift to the warmer side on the right. And this shift results in a larger jump in the number of extremely hot days and a drop in the number of extremely cool days. And overall, what the evidence is showing is that heat waves are going to be longer, more intense, more frequent, and they're going to happen at more unusual times. In terms of communication about heat with our patients, when we think about communicating about heat, there are a few different options that we can choose from. The ambient temperature is what we see on most of our weather apps. And the wet bulb globe temperature and heat index are generally more informative and useful measures for a clinical setting. Both the wet bulb globe temperature and heat index aim to fulfill the same purpose, which is to measure heat stress of the environment on the human body. Whereas heat index takes into account temperature and humidity, it's not always sufficient to use this metric. And that's why the wet bulb temperature was taken and developed. And in a nutshell, the wet bulb globe temperature is a more in-depth metric that takes into account more of the environment. And therefore, the wet bulb globe temperature is the best metric to use to calculate and monitor heat stress on the human body. And of course, it's important to put heat in the context of other weather-related hazards. After all, this is a course that is reviewing hazards, all the different hazards that can be caused by climate change. And what this bar graph represents is, and it is data from the United States, but as you can see, when comparing the deadliest weather-related hazards, extreme heat, kind of across the board internationally, is often considered to be the most deadly weather-related hazard. I think it's also important for us to remember that, while the case we were reviewing today was a case related to heat exhaustion and possible early stroke, heat-related illness can present in a lot of different ways. We commonly think of heat stroke and heat exhaustion, but many other patient presentations can be related to heat, including some of those listed here, including heat syncope, heat rash, heat edema. So, keeping those in mind, and for the same reasons as we were discussing about keeping our differential broad, being familiar with these different conditions that are related to heat is important, as we may be seeing more of these conditions crop up in the future due to climate change. It's also really important to remember that certain populations are more susceptible to heat-related illness, and some of those are listed here. And coming back to the case today, when it comes to the dreaded consequence of heat-related illness, which is heat stroke due to its high morbidity and mortality, it's important to distinguish between classic and exertional types of heat stroke, which are compared in these two columns. And I'll review those in a little bit more detail in the next slides. So classic heat stroke is commonly seen in the elderly population, and these persons often have a compromised ability to adjust to heat stress. Classically, they have poor psychosocial support. They may live in high-rise apartments. They may not have an elevator, or have poorly ventilated housing, no air conditioning, and fans that are really just circulating the hot air in the apartment. Classic cases have often a myriad of chronic health conditions and are on a host of different medications, including antihypertensive medications like beta blockers, diuretics, calcium channel blockers, laxatives, anticholinergic drugs, and others. And the clinical presentation for heat stroke is often an insidious onset for these patients. Symptoms may include nausea, tiredness, exhaustion, some neurological symptoms including disorientation, confused states, decreased cognitive functioning, and eventually progressing to pre-coma and coma. And patients may have an elevated temp and tachycardia. And since thermoregulation is compromised, they may actually have decreased sweating, dry skin, and decreased urine output, and worsening of their non-communicable diseases. A high index of suspicion and a careful history, as was taken today during our sample case, as well as recognition of a heat-related illness as a possible diagnosis in your differential, would lead one to arrive to a correct diagnosis. And for this classic type of heat stroke, the prognosis is generally poor and generally has or portends a higher morbidity and mortality than the exertional type of heat stroke, which we'll review here. This typically occurs in a younger population who are exposed to strenuous physical activity and prolonged exposure to sun. Athletes, laborers, firefighters, agricultural workers, and environmental workers are all examples of populations at risk. For acute presentations, usually their thermoregulatory mechanisms are intact, and a patient may be sweating profusely, may have damp or moist skin. And in terms of their clinical presentation, their oral temperature may actually be normal, and it's important here to try and take a core temperature, like a rectal temperature, to test their core temperature. And they may also have signs of dehydration, loss of electrolytes due to sweating, and keeping that in mind and looking for electrolyte abnormalities and getting an EKG is also important in these patients. For these patients, the prognosis is generally better, and they respond better to IV fluids and electrolyte replacements, and generally have a better course. And this is an important reminder, and something that we saw in the case today, that patients may not always be really forthcoming with their medical history, especially when it comes to their mental health history. So you may have to ask patients if they're taking any of these medications directly, and overall recognizing that certain medications, especially antidepressants, other psychoactive medications, and blood pressure medications, as well as other medications, can impair the body's ability to thermoregulate appropriately. And this is a schematic that essentially reviews the steps in managing a patient who you may suspect to have heat stroke. So overall, you're triaging early, you're taking the steps that we saw here today to try and recognize heat stroke. You're cooling the patient and beginning with external cooling measures and progressing to internal cooling measures only if necessary. And then beyond that, it's mostly about supporting the patient and doing close serial exams. But again, as the case today demonstrated, one of the most important things when we're triaging and in terms of recognizing heat stroke is taking a really good environmental history. And when we think about this and what we saw Lynn do today, there are three really key questions when we're taking an environmental history. And that includes, what do you do for a living? Do you work with any chemicals, and what is your workplace like? Are you exposed to any potential hazards in your home, community, or workplace? And do you think any of your problems today are caused by exposures that you have in your home or in your workplace? And from the case today, we gleaned from Lynn's environmental history that Jody worked in a not very well air-conditioned place with poor ventilation. And ultimately, this was really important for us in terms of conceptualizing what was going on and coming to the eventual conclusion that she was likely experiencing a heat-related illness and possibly heat stroke. And with that, again, I'd like to just thank both of our actors and all of the audience for all your wonderful participation. And we can have some time here for a Q&A. So please put your questions in the chat.
Thank you so much, Stefan and Lynn and Tasha. Really, really interesting presentation. A couple of questions we have here in the chat. The first one is, Stefan, can you maybe talk again about what wet bulb globe temperature is? Because I think we went through that a little quickly. Is that something where we can find that information online, or how would we get at, knowing what the wet bulb globe temperature is, and maybe talk about what goes into that?
Yeah, absolutely. So as I'll just maybe share my screen here again, and we can go over some of the comparison between the wet bulb globe temperature and the heat index to help people understand that a little bit better. So again, it's just it's a measure that is attempting to measure heat stress on the human body, and it's generally considered to be the best measure that we have, and it's generally just taking more factors into account. So whereas you can see here on the right that the heat index does not take into account the a temperature that's measured with direct sunlight. The wet bulb globe temperature does take that into account. Similarly, the wet bulb globe temperature takes into account wind, cloud cover, and the angle of the sun, whereas the heat index does not take those factors into account. So it just includes more environmental factors in that composite index, and it is something that can be found online. There are different resources. I don't have any on hand that I can pass around, but there are resources online that you can look up your wet bulb globe temperature for your local region.
Thank you so much, Stefan. Crystal put an interesting story in the chat that he says, I know a guy who works outdoors. They were doing work on a highway and he suffered a seizure. His relatives were contacted and they insisted that he was okay and didn't need a doctor, but his boss was convinced that it was the heat. And eventually he got no medical attention. And this sort of makes me wonder, how aware is the public, are clinicians in the Caribbean region about heat illness? And I'm wondering if Lynn and Tasha and maybe James and Paula and Lauren have some comments on this in terms of how aware is the public and how aware are health professionals and health systems about heat illness being an issue? And anyone can jump in.
Yeah.
You go first, Paula.
Yeah, I would like to say something. I became very aware of this because two of my workers, they were both in their early 20s and they both had syncopal episodes. Can you hear me?
Yes.
I became aware of this because two workers, they were both in their early 20s, cleaning my pool, and they both had near syncopal episodes and they were taken in. I think, if they didn't have IVs and if they weren't taken in by their co-workers right away, they may have died. Anyway, there was no diagnosis or no thought that they might have had a heat-related illness. So I did inquire about them. What did the doctor said? One said, the doctor said, because I didn't eat today, and that's why I got sick. And the other one, the doctor said, because his hemoglobin was so low, he became ill. So I think it's something we need to become very aware of because this is going to get worse. And what made me very suspicious is because they were both young and they both got very ill within a few days of each other. And they had no known illnesses, but one boy was found to have had a sickle cell trait, which we know in the Caribbean, people who have traits can decompensate in times of stress, and heat would be one of them. And the sickle cell trait is 10% in our region. So we need to become very aware that this may become a problem in the future. Thanks.
Second, what Paula is saying, I think in a lot of cases, heat illness isn't as emphasized as an actual illness when people come in, and there isn't that much awareness of it as a real problem. I mean, it may be compounding other things like hypoglycemia and anemia and other things, but you don't see a focus on it. I think education courses like this one are really good for raising awareness for clinicians across an entire region, i.e. the Caribbean, where, I mean, we are tropical, and it's good that people are now aware of how a patient can present and the range of things that you need to look for and hear stories like Paula's with her two guys. just to be aware that, you know, factor it in, consider it. It may not necessarily need to be that, you know, it's the hottest day or they've been at the beach, but just the fact that they've been having symptoms over a couple of days, it could be a little bit more insidious, and just a bare note.
So in my experience, I think is remembering that heat illness is on a spectrum. So particularly like working in, let's say, a private clinic where I'm seeing a lot of tourists and stuff, obviously it's something you keep more in mind because that goes from like heat cramps to heat edema, you know, so the consideration is, okay, maybe this may be a problem acclimatizing. And I think that it kind of, not case of bias, but you kind of think, okay, I live in the Caribbean, I'm accustomed to heat, just like Jody was saying, like, you know, but my friends are cooling down without realizing that there are other factors that impact that. I think when you see marathon runners who faint, have syncopal episodes, etc., it definitely becomes a consideration in the ED. I think another way that we consider it a lot is with elderly patients who've probably been found like in their homes with like altered mental status. The same way you think about them having rhabdomyolysis and that causing the issue. Heat illness is also considered, but the reason why I love this case that Tasha and I presented is because Tasha is young, vibrant, as she said, she was high on life, you know, and yet heat illness affected her, even though, you know, she should be accustomed. So I think that's a point for all of us to think of it, not only in the marathon runners, to think about it, not only athletes, to think of it, not only in the tourists, but that with rising temperatures, it really can affect anyone.
Thank you
Lynn
all.
made a really, sorry, go for it.
No, you go.
I was going to say,
it is
Lynn
getting
made,
hotter. You go
Lynn made a
ahead,
really,
Tasha.
sorry. Oh, sorry, Jimmy. I was just going to say, Lynn said one really interesting thing, which I knew came up in the news a fair bit in Trinidad, which is that, you know, elderly people presenting and being left at home during COVID and the isolation period and lockdown period in Trinidad. There was an increase in elderly people being found at home because relatives couldn't go in to check on them and they were neglected, basically. And, you know, I mean, possibly some of those cases could have been from heat illness because they would have been a vulnerable group. And then, you know, just the heat, you don't know how many of them maybe didn't have access to good ventilation and air conditioning and that kind of thing. So just the more global factors, things like that. I think that's a good point that Lynn made.
Mm-hmm. So I want to move on to the next topic. Oh, sorry, go ahead, James.
It's been very educational working on this. It is getting hotter, even though we think, you know, we're in the islands and it's cool. It is getting hotter. And if you see from the TT Met Office, Trinidad and Tobago Met Office, they are now putting out more regular heat maps. And it's not infrequent that we have temperatures way above 40, wet bulb heat. And I saw Dr. Manzanero in Belize mentioning some really high temperatures. I think one of the things I learned in this process was how medications and therefore a history of what asking people what drugs they're on is important. You know, and our old mnemonics of tin can, bed made, is it trauma, is it infection, is it neoplasm? It kind of falls down with this one to remember it. Certainly when I used to do triathlons, I remember getting overwhelmed by the heat and being dehydrated some years ago during a sporting event. But a lot of other vulnerable groups need to be considered. I see Dr. Buckland's mentioning something that my wife, who's a veterinarian, goes on about, and that is people who leave their dogs in the car and leave the windows rolled up. And it can get to over 50 degrees Celsius very quickly, and the poor animal dies.
So I want to move on to the next question. We've got some great comments in the chat. And the issue of mental health was raised. Marvin brought up, you know, India has been experiencing an extreme heat wave right now, and they've been seeing increased rates of suicide. So maybe we can comment a little bit on that. And Karanique has a question: as a psychologist, or as, you know, anyone who's a mental health professional, you know, what should they be looking out for in terms of early symptoms of heat stress that would, you know, raise their attention that maybe they should refer this patient to an emergency center? So I'd love to hear this panel sort of maybe comment on both of those things, you know, this increased risk of suicide during heat waves or mental health exacerbations during heat waves. And then, you know, what can the outpatient community behavioral health system do to sort of have a lookout for this?
So any person with a mental health disorder, you have to be very careful during heat waves because there would be increase in mania, there would be increased violent activity. There would be persons who, there would be increased violent-based behaviors with wives, right? Increase. So we have to be aware that that would occur in all patients who have mental illnesses. So in our case, where we have a lot of violence based in homes, we have to be aware of this, and we have to counsel our families, our wives, our children, that, you know, that this would happen, that things would be getting worse in the home. So we have, as family doctors and as family physicians and as environmental people, we have to bear this in mind and take the steps ahead of time.
Compliance is probably also something that, as Paula was saying, you know, you need to counsel families on as well, because for those who tend to be more sensitized, like your mental health patients, like Jody was, to heat, they may be less inclined to taking their medication in the regimented way that they should. And so family needs to be counseled to just be aware of the triggers and, you know, the alarm signs to look out for, just so that they're aware of, you know, how they keep a check on their family members before they do end up in the ED with a violent episode of some kind. So I think that that's probably really important, is counseling families about compliance with medication.
Yeah, I know there's definitely been some really interesting research on this recently. You know, during heat waves, we see increased presentations of psychosis among schizophrenic patients. And you know, that could that be linked to, you know, the heat or to the medication or a combination of the two? So I say, you know, as an outpatient psychologist or as someone who's working in the community, you know, if you notice sort of an acute behavioral change among one of your patients, you know, especially if it's hot out, you know, it's definitely a time to refer them to a higher level of care for more evaluation. I think that, you know, irritability, or, you know, you mentioned sweating, you know, if you were in the office with them and looked like they were, you know, really overheating, having flushed skin, sometimes they can even be dry depending on the medications that they're on, but, you know, sort of having your eye on them physically as well as what they're saying to you, you know, those could be some early signs of heat illness that could require a higher level of care in terms of medical attention. So thank you for those comments. Well, this has been an incredible panel. You know, I think, you know, maybe some closing thoughts from James about sort of what you're thinking in terms of, you know, how the Caribbean, how can we prepare more of the health workforce, right? You know, we are 120 people here today. So how can we spread the word about this? And how do we create more sensitization around this, right? Because I don't think it's on the top of everyone's differential, but we're heading into the hot season right now. So how can we spread the word on this? Curious to hear what this panel thinks. Maybe James, you have an idea.
Yeah, thanks, Cecilia. Well, I think this needs to be inserted into our undergraduate training programs. We have over 40 medical schools in the Caribbean. I think continuing medical education as well. I think our chronic disease programs that are treating hundreds of thousands of people with diuretics, folks with mental health problems that are on psychotropic drugs. And I have to confess, I didn't really make that connection, that some of these drugs make you at greater risk of heat illness and heat stroke. So these are some of the things that need to become, we need to think about it and have that actually as part of our differential. Over.
Thank you so much. And someone here in the chat is saying that media needs to be involved. I mean, absolutely, right? You know, our weather forecasters should be talking about, you know, the risk of heat and health, right? You know, because they can say, okay, there's a huge heat wave, but, you know, if people don't know what to do if there's a huge heat wave or what kind of symptoms to look out for, I mean, that's a really great thought and a good opportunity for where we as health professionals can kind of educate those who really carry the messages about weather and climate to be more savvy to the health impacts that could come afterwards. So, well, this has been an incredible case. I want to do a special thanks to Lynn, to Tasha, to Stefan. You guys are great actors, by the way. And thank you so much to Paula and James for coming onto the panel. We are going to be having another clinical case it's 2 weeks from now, and we look forward to seeing you there. And otherwise, we will see everyone tomorrow at our normal didactic class. So thank you all and have a wonderful evening. Take care.
Thank you, Cecilia. Thank you, everyone. Bye.
Bye. Bye, everyone. Have a good evening.